speaker is Robbie Maillard. He's an assistant professor in the Infectious Disease and Microbiology Department at the University of Pittsburgh. His research is focused on development of DC-based immunotherapeutic strategies, and the title of his talk is Type-1 Programmed Dendritic Cells Induce Primary CTL Capable of Effectively Targeting the HV1 Reservoir.
Thank you. I'd like to thank the organizers for this opportunity to present some of the work we've been doing at the University of Pittsburgh, where we've been focusing on the use of dendritic cells as an immunotherapeutic tool for the purpose of inducing effective CTL responses to target the latent reservoir as part of the kick and kill cure approach. Now, while we think that the CTLs are going to be essential in this kill, there are a number of hurdles that we think we're going to have to overcome. One of them being that HIV effectively evades the CTL responses through the establishment of CTL epitope escape variants. And also, there's a predominance of dysfunctional HIV-specific CTLs that continue to persist throughout the course of infection, yet fail to have much influence on viral evolution or viral control, suggesting that they're just not providing the selective pressure needed to do its job. But we think that we can overcome some of these issues if you use properly programmed dendritic cells. And we can do this either by reconditioning or retraining the pre-existing memory CTLs to make them work better, or through the priming of brand new CTLs through the naive T cell population and use them to target the HIV reservoir antigen. Now, the type 1 polarized dendritic cell is a dendritic cell that we're quite fond of. And what this is a monocyte-derived dendritic cell type that's specifically programmed to express a number of desired traits that we think are pretty critical for in driving cell-mediated immune responses. And these cells are characterized by, first, their mature status. They're expressing CD86 and CD83, and also they're capable of homing to the lymph node expressing CCR7. But what makes them unique is this last point, that once they get to the lymph node, we want them to be able to make IL-12, specifically when they're interacting with their T cells. And these dendritic cells are programmed to respond at a later time point to the subsequent signals they'll receive from the T cells. In this case, CD40 ligand, the T helper cell signal. And then the cocktail cytokines that we use, and this is not the only type 1 polarized dendritic cell cocktail, but the one we're using here today that I'm showing you is a combination of TNF, IL-1 beta, interferon alpha, poly-IC, and interferon gamma. And this is a cocktail we came up with a number of years ago that's clinically applicable. And it's actually being used quite a bit now in the cancer world. Now, in addition to responding to CD40 ligand by producing IL-12, these dendritic cells also have this other unique characteristic. This was published recently by Colleen Zacard from our group, and that is they undergo this really interesting morphologic change when they interact with the CD4 T helper cells, and this is induced by CD40 ligand. And it's a trait exclusively a property of the DC1. And so as they reticulate, they give off these tunneling nanotube extensions, and it creates this cellular network between the cells. And what this does, it allows the dendritic cells, it facilitates their immune communication between one another, where intracellular components can be trafficked, can go through these tunneling nanotubes, such as antigen, endosomes, even mitochondria. And I think this is really important because once the dendritic cells get to the lymph node, it's been shown in some of the more recent publications from people like William Heath that they also need to interact probably with the resident DCs that are there. And we think this may be one way that this can facilitate this interaction. Importantly, we want to see if compared to more standard ways of making dendritic cells, if our dendritic cells can indeed prime naive CTL responses to HIV. And so what we did first, just as a proof of principle, is we took some HIV negative subjects and tested them out in vitro. And to cut to the chase, our type 1 polarized dendritic cells are much more effective at inducing CTL responses. But I want to mention a couple things. One is that CD40 ligand help is critical, and CD4 cells are critical to this, but we can substitute the CD4 cells by providing the CD40 ligand in an exogenous way. And another thing I'd like to point out is that this is just interferon gamma responses by ELISpot assay. It's a typical ELISpot assay, but it doesn't show what's really important, and that is can they kill? And you can see in this video where the smaller cells are the T cells that have been primed against this GAG epitope, this 9-mer, that these monocytes in this case, actually they're macrophages or immature DC precursors that are expressing the antigen that these T cells were primed against. So this is a type of response that we're looking for. We want to see the true killing response. But for the study, what we're really interested in is how well we can use these dendritic cells in the setting of true HIV infection. So the purpose of this work was to see if we could utilize our type 1 polarized dendritic cells to either correct or recondition these memory T cells that may be capable of recognizing the virus, but at this point dysfunctional, or if we can prime naive T cell responses that we can generate into CTL that are capable of recognizing the autologous virus. We do this by utilizing the multicenter AIDS cohort study, the Pittsburgh MAX cohort, and these patients have been, or these subjects or participants have been absolutely fantastic. They've been willing to give us large blood draws every time we ask them. Because we really need this, because this is a pretty complex protocol. And so we do the sorting of the memory cells and the naive T cells, and I'll show you what we get as far as the results, first by ELISpot. The top row here, this is ELISpot. These are ELISpot results looking at interferon gamma responses to autologous GAG P17 and P24 peptides that's spanning the whole proteome. And you see both on the top, these are 3 subjects. On the top, this is the memory responses, and on the bottom, these are the responses we're generating from the naive T cells. And we're getting very nice interferon gamma responses from both populations. But I will say that there's a bit of a greater magnitude with the naive population, and also the breadth is a bit greater, where they're targeting both conserved and variant epitopes, while the response here in the memories are a bit more just not quite as broad. But what's important is that they're both making interferon gamma. But if you look at the true killing capacity of the 2 populations, you see something quite a bit different. And that is when the T cells that we're getting from our naive population in this killing assay, where we superinfect the CD4 positive T cells, and using flow cytometry we can detect the antigen of the infected cells. And when we titrate the CTLs generated from these 2 populations, the disappearance of this HIV positive population would indicate killing, and we get very nice killing with our priming of the naive T cells, but not the memory. And this seems to be the case every time, for the most part, so far at least. And this is just showing 3 patients, but we've actually shown this with 5 now, where we're getting this same pattern. So it's interesting that the memory cells are responding, and we're getting very nice interferon gamma responses, but this lack of killing. And we think we can explain this by some of our earlier findings, where at least this is our hypothesis, is these CTLs that we're generating from the memory population were probably induced from an earlier founder strain, and now they're reacting in a cross-reactive manner to these late epitope variants. We were able to show how this could be done in vitro by priming naive T cells from an HIV negative subject this is actually the same CTLs we showed in the video, where they're primed against the TV9 peptide, and by just modifying the peptide by one amino acid, and this would represent a variant antigen, we can see very nice TNF and interferon gamma responses by flow cytometry, but only the killing is occurring against the T cell epitope that they were primed against, and not the variant. One interesting thing I want to point out, though, is when we get this successful killing, we get this downregulation of CD8 occurring, and we don't get this downregulation in the case of the cross-reactive variant. And if you look at the patients, or the participants that we looked at, this is just one of the participants, and these are the dominant memory responses from this one subject, S2. You see the same sort of pattern where we don't get this downregulation of CD8 that's associated with killing. Only in 1 out of 6 are we getting this downregulation. And I'm not showing you the data, but this is actually a very good killer population of cells, while these other ones are weak killers. So not all the memory cells are bad if we can target those specific ones, but we believe that this is going to be a problem when the predominance of the memory cells are behaving this way. Another thing I want to point out to you is that the study that we're doing at the moment, we're really looking at subjects who've had a significant delay in therapy from the time of seroconversion, typically around 5 to 8 years before they've had their antiretroviral therapy started. And during this time, a lot of things can happen. We think that this is an issue. And we also think that if you use subjects that are initiating ART early in the course of the disease, we may be able to, this may be a benefit by allowing the variants not to get established, the variant epitopes, and also this dysfunctional CTL response will be less likely to occur. So in summary, we showed that HIV-specific CTLs can be primed using the naive T cell pool against the autologous virus using the type 1 polarized dendritic cells. However, when we use these type 1 polarized dendritic cells to activate the memory CTL response, they still display quite a bit of dysfunctional responses against the reservoir antigen. Showing cytokine production in the absence of killing, and we think that this may contribute to the chronic inflammatory conditions we typically see with HIV. So we propose that dendritic cell immunotherapies to treat HIV should target the induction of de novo CTL responses by targeting the naive T cells, and that early initiation of ART may help by limiting the establishment of the epitope variants and this dysfunctional CTL memory issue. And I'd like to acknowledge a few people, Chuck Ronaldo, who's the leader of our group at the University of Pittsburgh, Kelly Smith, who's done a lot of the priming and who's a recent graduate from our program, Colleen Zicard, who just published this paper on DC reticulation and who also just graduated. Paula Piazza is now currently working heavily on this to try to get it into the clinic, along with our friends at the University of Pittsburgh Medical Center, John Mellors and Beej Makatange. And I'd especially like to thank the MACs and the MACs participants. They've been absolutely fantastic, and it's such an instrumental group for us to use. And I'll end it there and take any questions if you'd like.
Questions?
Sure.
My name is Bob Palermo. I'm a consultant with the Gates Foundation. I was curious with respect to the contrast for the memory response versus the naive cells that you mature to CTLs. Normally in an ELISA assay, you're really sort of giving it a lot of peptide in an antigen presentation environment, as opposed to the killing assay, which might be much lower. That's where the available concentration of ligands would be lower, possibly. I just wondered if you had occasion to sort of do the examination to look at the proper formulation of immunological synapses between the CTLs and the infected targets, in order to see if they're actually forming properly from the memory cells versus the newly activated naive ones.
I think it's a good question. In fact, I think that the fact that the CD8 is not being downregulated, which is a typical the end stage of a really good, strong TCR binding and a good TCR response, that the CD8 and the CD3 will get downregulated. Just the fact that they're not being downregulated suggests to me that the binding is not very tight in the cases with the memory responses. And I think that's, and it fits with our model when we use our variant peptide. However, the binding of the peptides to the MHC class 1 are fine. And sometimes they're even a higher binder than the original founder peptides. But I hope that answered your question. I'm not sure if it did. The concentration of peptide, in fact, we are using quite a bit of peptide for both the ELISpot, but in this case, we can use targets as part of our ELISpot, where we just paint the peptide onto the targets, and we get the similar results.
Okay. I mean, I guess what I was trying to get to was whether it was a defect in the memory response that abrogated efficacy, even if it was binding as well as the sort of newly matured CTLs. But you're suggesting that they aren't binding as well. Yeah,
and it's actually been shown by a number of people in the past that the variant epitope can act as a partial agonist and have this weaker binding at the synapse.
Hi, very nice presentation. So, do you have a hypothesis for why the effective CTL are not being primed in vivo by the autologous antigen?
I actually think they are being primed very nicely at the early stages of infection. I think they function very nicely, and the virus loads do drop. I just think that the virus is just tricky.